Hello, ladies and gentlemen. I am Young-Seok Lim, the program director of APASL Hepatology webinar in this year. It is my great pleasure to open this month's webinar with the title of New Drugs for Hepatitis B under Development. Currently, many novel classes of new therapeutic agents are being very actively developed with the aim of achieving functional cure of hepatitis B. Although those agents are currently in early phase clinical trials, there is a high possibility that those will be widely available in upcoming 10 or 5 or 10 years in clinical practice. Therefore, it would be very important to know and understand the progress of those clinical developments for better planning and counseling current treatment in patients with chronic hepatitis B. Today, we have invited 4 very important world-renowned speakers. First of all, I am more than happy to introduce the chairpersons of today's webinar, Professor Jidong Jia and Professor Tawesak Tanwandi. Professor Jia Jidong is a hepatologist and the director of the Liver Research Center at the Beijing Friendship Hospital, Capital University in Beijing, China. He is also past president of the Chinese Society of Hepatology, past president of APASL, vice president of IASL, International Association for the Study of the Liver. Dr. Jia also serves as associate editor for a Journal of Gastroenterology, Hepatology, Hepatology International, and Liver International. His clinical research interests includes the chronic viral hepatitis and autoimmune hepatitis. Professor Tawesak Tanwandi is a hepatologist at Sriraj Hospital, Mahidol University, Bangkok, Thailand. He is immediate past president of the APASL and also served as president of Thai Association for the Study of the Liver and the president of the 4th ASEAN Perspective in Liver Disease in 2016. His research interest is about treatment of chronic hepatitis B, C, and hepatocellular carcinoma. Please welcome Professor Jia Jidong and Tawesak Tanwandi, please.
Thank you, Professor Lim. Good evening, good morning, and good afternoon to everyone around the world for attending this APASL Hepatology webinar today. So today we're going to have 4 speakers. Myself is Tawesak Tanwandi from Bangkok, and together with Jidong Jia from Beijing, going to moderate this session. This is going to be the new drugs for hepatitis B under development. So the first speaker going to cover on the following in the part of anti-hepatitis therapy, old, present, and future perspective. This is going to be delivered by Professor Fabien Selim. Professor Fabien Selim is now Professor of Medicine at Lyon University, France, and he also medical director of Hepatology Department in Lyon in France. I think everyone knows him, and he has done quite a lot in hepatitis B, especially on basic research. And he is currently coordinating on the hepatitis B cure task force in France.
Okay. So do you see my screen or not?
Yes, please make it out. Good.
Is it? It's okay? Okay. Okay, thank you. So good evening, everyone. First of all, I would like to thank Professor Lim and all the course director and the APASL governing board for this kind invitation. I will give you an overview on the present and future prospect for anti-HBV therapy. So you see here my, oh, I don't know why slides are going automatically in my disclosures. So regarding current treatment, as you all know, we have currently nucleoside analogs that are effective in obtaining long-term viral suppression that is associated with a decreased inflammation and fibrosis, as well as a decrease in the risk of hepatocellular carcinoma incidence. However, as you all know, the risk of HCC is not completely eliminated with the current antiviral treatments, despite an efficient viral suppression. Moreover, the long-term viral suppression associated to nucleoside analog therapy is associated with an HBs antigen loss rate, so a functional cure of a maximum of 10% after 5 years of therapy in selected cohorts of patients, so, which means that lifelong therapy is required in the majority of chronically infected patients. There has been some new development in the field of nucleoside analog therapy. So beside entecavir and tenofovir, TDF, there was a recent development of a prodrug of tenofovir, which is tenofovir alafenamide, or TAF, which is associated with a quite similar antiviral efficacy with a similar rate of viral suppression. But what is important is that the safety profile of TAF was significantly better than the classic tenofovir, with an improved safety profile regarding kidney function and bone density. So this should be kept in mind when we are treating patients if TAF is available in your countries. Now we would like to move beyond viral suppression and try to achieve an HBs loss, or a cure of the infection, with finite duration treatments. So functional cure has been defined as the next attainable goal by the different international societies for the liver, so AASLD and EASL, which had a joint workshop two years ago to define this goal. So functional cure is defined by a sustained HBs antigen loss after stopping therapy, with or without anti-S antibody seroconversion. And this is associated usually with a decline in cccDNA, but however, with its persistence and with the persistence of integrated viral forms. There are more ambitious goals, which are a complete cure and a sterilizing cure, but this will be addressed later on with newer strategies. Regarding the functional cure and HBs loss, the first question was, how durable is it with the current drugs that we have, so with nucleoside analogs or PEG interferon containing regimens. So Professor Analog has done a retrospective studies of 3 phase 3 clinical trials with more than 1,000 patients that were treated with either tenofovir or interferon, or a combination of tenofovir and interferon. And what was the finding were interesting in the sense that when we define HBs antigen loss as 2 or more consecutive negative HBs results with a minimum of 1 repeat after the end of treatment, so a very stringent definition, we see that the majority of patients achieving HBs loss will have a sustained response after stopping therapy. And this was the case whether patients had an anti-S antibody seroconversion or not. So the anti-S antibody seroconversion, when using this definition, is not necessary to define a functional cure. Moreover, a study performed in Hong Kong, a very important study, showed that what we already knew is that complete viral suppression decreases the rate of HCC incidence. But what was very important in that study is that HBs antigen loss, as you can see here, further reduces the HCC risk after complete viral suppression. So this is a second argument to our goal of achieving HBs clearance. So these are the two main arguments, I believe, with the drugs that we already have in our clinics. So in terms of guidance for design and endpoints of clinical trials in chronic hepatitis B, there was a very nice summary published recently in Journal of Hepatology and Hepatology from this EASL-AASLD joint workshop, which defined a realistic functional cure. And as I said, it is defined by an HBs antigen loss with or without anti-HBs antibody seroconversion. HBV DNA is not detected. Patients are in viral suppression. And when we look in the liver, CCC DNA is detected, but is supposed to be not transcriptionally active, while integrated DNA can be detected. So the risk of liver disease is decreasing with less fibrosis and a decline in HCC risk with time. Now, regarding this HBs loss and functional cure, there's a lot of discussion of how we can improve this HBs loss rate with the current drugs that are available. And one of the scenarios is to stop nucleoside analog therapy in selected patients. And this is extremely debated in the field because they are, depending on the studies, we see different type of results. There are two main scenarios. One is when which is shown in blue, is that you have a small relapse of viral replication, and then the viral replication is controlled by the immune response, and we may see HBs antigen decline and HBs antigen loss. So this is a favorable outcome. But another scenario is that viral replication rebounds, and is associated with severe ALT flares or elevation of ALT with reinitiation of the chronic disease, and which would require retreatment and quite early. So this is really debated, clearly, when you look at the literature, the rate of HBs antigen loss when you stop treatment varies from 0 to 33%, so quite a wide variation, and the rate of clinical relapse varies from 6 to 70%. So this underlines the heterogeneity of these studies. So here I'm just showing you an algorithm for stopping nuke in chronic HB antigen negative patients that was proposed by EASL clinical practice guidelines. And clearly in the EASL guidelines, the stopping nuke therapy is only proposed to patients with an HBe antigen negative disease, with viral suppression for more than 3 years, who do not have an advanced fibrosis and obviously no cirrhosis, and for whom post-treatment monitoring is possible. So if patients meet all these criteria, then there are also other biomarkers such as the HBs antigen levels, which should be below 1,000 or even less, 100. And in that situation, we may consider stopping nuke and monitor. In all the other situations, nucleoside analog therapy should be continued to avoid any risk of relapse. Now let's move to the future and whether we can discuss new therapies to achieve higher rate of functional cure, and this will be the subject of the three following talks with our distinguished experts. As a summary slide, has been in the past 10 years really a lot of drug discovery effort, a lot of translational research to understand the mechanism of viral persistence, both on the immunological side and the virological side. And from these experimental studies, we could move to clinical studies, and this allowed to really characterize novel targets for antiviral therapy, characterize a mode of action of new drugs, which are now developed in clinical trials with the help of novel biomarkers. And these clinical trials will be discussed in a few minutes, and with the aim of improving the cure rate and prevent HCC risk. So just to give you a summary of these emerging treatment targets, we have strategies that are trying to be curative, targeting the pool of cccDNA. These direct strategies to target cccDNA are mainly at the preclinical stage, so in experimental models. And there are several strategies that are trying to control viral replication in a much more efficient way than what we do with current nukes. We addressing pre and post cccDNA targets. They include entry inhibitors, strategies targeting viral RNAs such as siRNA, antisense oligonucleotides, capsid assembly modulators, novel nucleoside analogs, and inhibitors of HBs antigen release such as NAPs and STOPs. The second class of strategies that are being evaluated are the immune modulating strategies with innate immunity modulators. These innate immunity modulators include TLR7 and TLR8 agonists, and the strategies to invigorate adaptive immunity or stimulate adaptive immunity with checkpoint inhibitors and therapeutic vaccines, for instance. So all these novel strategies will need also the help of biomarkers to assess target engagement and predict treatment endpoints very early on during clinical trials. And beside the classic viral load that you all know, and sorry, the slides are moving in an uncontrollable manner. Beside the viral load biomarkers that you all know, and the quantitative HBs antigen, there are novel biomarkers that include circulating viral RNAs and CREG, HBC-related antigen, that may reflect in a more accurate manner the pool of transcriptionally active cccDNA. But these are still investigational biomarkers and may be very important in the future to assist drug development. Looking at the key considerations for clinical trials of new drugs, obviously we need to make sure of the safety of the profile of the new strategies. We need to have biomarkers to predict endpoint achievement and guide therapy. We need to have novel drugs, which we have now, and we need also to address the heterogeneity of patients' population. So regarding safety, and mainly the liver safety, so we can distinguish different types of flares during therapies, and especially during novel therapies. Antiviral flares, virus-induced flares, but the most scary one is a drug-induced flare. And this may be identified by different characteristics: the timing of flares, the course of the flare, the association with HBV DNA kinetics, the elevation of alkaline phosphatase, bilirubin level, and very often, in case of doubt, we need to go to liver biopsy. And we had an unfortunate recent experience with a RIG-I agonist in Hgb, which ended up in severe side effects, and the drug was withdrawn from development. Regarding the novel drugs that I showed you before, I think we could classify them in different big class of drugs, replication inhibitors, strategies to reduce viral antigen expression, and strategies to invigorate immune responses or to stimulate HBV-specific responses. And the really the challenge now, but this is the exciting time, is that we have many assets and we need to see how we are going to evaluate these different combinations in clinical trials to improve the functional cure rate. Another consideration is in clinical trial design is the timelines. So one question is whether we should obtain HBs antigen loss, the functional cure, by the end of therapy, so before stopping all treatments. And here the help of biomarkers will be important to help us to guide the treatment regimens, or should we wait after treatment withdrawal to, for instance, to have the flare phase that may help in the consolidation and increase the rate of functional cure. So depending on the mode of action of the drugs and the expected mechanism of the combination trials, the time points and timelines may be different. Another important consideration is patients' heterogeneity. As you all know, patients belong to different phases of the disease, and they may, each individual patient may go from one phase to the other, which makes the scenario complicated. But we need to address all these heterogeneity in clinical trials so that we match the real life. So obviously those with high replication, with inflammation are the priority, but we shouldn't forget the inactive carrier or the virally suppressed patients, as well as the immune tolerant patients, and the special population with cirrhotic co-infection with HIV, transplant patients or children. In the clinical trials, most or many of them uses a stratification of patients based on e antigen status, viral genotype, viral suppression, the level of HBs antigen. So these trials are not easy actually to design to achieve a relevant, clinically relevant result. Based on also on the new trial design that were developed in the field of oncology, we have learned that there are master protocols and mainly the platform protocol for big pharma, which have different assets and mode of action. They can use these platform trials because they can study multiple targeted therapies in the context of a single disease in a perpetual manner, with therapies allowed to enter or leave the platform on the basis of decision algorithms. So this is a single infrastructure which is ongoing over time with a common control arm to aid in efficiency. But besides these big trials, I think we shouldn't forget the exploratory trials to investigate different treatment regimens in different phases of the disease. Now to come to an end, I think we are at a stage where we have many new antiviral drugs and immunomodulatory strategies that will be detailed in a few minutes, where we can now assess the concept of whether we can obtain a functional cure with a combination of direct antivirals, or whether we will need to add on the top of a very potent inhibition of viral replication and viral antigen expression, try to add immune response invigoration or immune stimulation in more complex clinical studies. So we will see in the next few years whether one or the other can achieve this goal of functional cure in higher proportion of patients. Now, I hope I've convinced you, and this will be discussed in the next 3 talks, that we have now all the assets to achieve a functional cure in the next decade, and we are really hopeful for that. And this was made possible because of all the research efforts made in drug discovery, antiviral research, immunotherapeutics, and clinical trials. But we shouldn't forget the access to care once this regimen will be approved, and all this public health issue of linkage to care when patients are diagnosed. And with this, I would like to thank you for your attention.
Thank you very much, Professor Salim, for your coverage on the perspectives of the treatment for chronic hepatitis B. So we're going to have Q&A at the end of the webinar. The next speaker is going to be Professor Manfang Yuan. Professor Manfang Yuan is now Professor of Medicine. He's actually Li Shu Fan Medical Foundation Professor in Medicine and Chair of Department of Gastroenterology and Hepatology, and as well as the Deputy Head of Department of Medicine at University of Hong Kong. He is one of the world-class clinician scientists on the field of treatment of chronic viral hepatitis B and C, and he is now leading almost all, but not at least many international clinical trials on the new drugs on the treatment of hepatitis B. Professor Yuan got to cover on the direct-acting antiviral nucleic acid targeting. Professor Yuan, please.
Thank you, Chairman. Can you hear me? And can you see the slides?
Yes, we can see the slide well.
Okay. All right. First of all, I would like to thank the organizing committee of APASL for inviting me to talk on this topic entitled Direct-Acting Antivirals Targeting Nucleic Acids. I would mainly concentrate on short interfering RNA, in short sRNA, and antisense oligonucleotide. And here are my disclosures. Before we discuss the novel nucleic acid targeting agents, let us quickly review what we can achieve with the existing therapy. Using nucleoside analog, practically all patients would have profound viral suppression when they are on treatment. Less than 20% of patients have partial cure after stopping therapy, but they still have low-grade viremia. Disappointingly, only a few percent of patients can achieve functional cure even on long-term therapy, but once it is achieved, the HBV DNA negativity can usually be maintained after stopping therapy. What leads to functional cure? What we know is that there is a decrease in viral replication and viral antigen levels, and there is also an element of enhanced immune control. For spontaneous functional cure, we still don't know which pathway comes first. For treatment-induced functional cure, we can possibly try by lowering the viral replication and viral antigens by direct antiviral agents, which may be associated with immune reawakening. Another way is to boost up the immune control by directly adding the immune modulatory agents. Advancing our goal from partial cure to functional cure, we only need to have a trigger point from surface antigen positivity to negativity in our patients. It is, however, easy to say than to be done with the existing therapy. It seems that we need more new agents to fight in this battle against hepatitis B. We know that effective treatment comes on the interplay between direct antiviral agents and immunomodulators. For novel direct antiviral agents, we have sRNA, ASO. They will be discussed in this talk. We also have core protein allosteric modulators, surface antigen release inhibitors, and HBV entry inhibitors. They will be discussed in a subsequent talk by Professor Robert Gish. For novel immunomodulators, in addition to interferon, we have toll-like receptor agonist, immune checkpoint inhibitors, and therapeutic vaccine. The upfront low-fold direct antiviral agents are siRNA and ASO, highlighted by the green and yellow boxes respectively. Most of the siRNA and ASO programs only have one single trigger, which usually targets the X region. There are also other siRNA triggers targeting the S region. The intracellular RNA degradation process is quite different, as illustrated by the green and yellow arrows in the right diagram. For siRNA, the RNA lockdown is mediated through the reads, whereas for ASO, it is a RNase H enzymatic degradation. Because of the different molecular properties and degradation process between siRNA and ASO, siRNA can be given with a less frequent dosing, but would require a dedicated carrier, for example, the GalNAc. Whereas ASO requires more frequent dosing, but may not need a carrier molecule. So let us look at the various siRNA and ASO program. This slide presents to you, this slide presents to you the earliest chimpanzee and human studies using the first generation siRNA, ARP520, which is only effective in knocking down the RNA transcriptional activities from cccDNA, but with minimum inhibition for the activities from the integrated HBDNA. As such, the RNA lockdown is suboptimal in E-negative chimps and patients who are expected to have more integrated form of HBDNA than E-positive counterparts. Because of this pitfall, better siRNA triggers covering both the cccDNA and integrated HBDNA have been developed. In this study, J&J3989 with two triggers targeting the X and S regions were given with 3 monthly doses to nucleoside analog treated patients. It is associated with a prolonged and sustained surface antigen reduction of 1.5 to 2 log, as assessed at 3 months after the last dose of J&J3989. Notably, 98% patients achieved more than 1 log reduction at the nadir. This study also showed that the viral antigen reduction was more prolonged for surface antigen compared with E antigen and correlated antigen. However, the degree of reduction was similar between surface antigen and HB RNA. In fact, this effective 3 monthly dosing regimen had been proven with a sustained medium-term surface antigen reduction till 11 months after the last dose of J&J3989. For responders defined as more than 1 log surface antigen reduction, the median surface antigen reduction was greater than 2 logs. Even for study-defined non-responders, the surface antigen reduction was greater than 0.5 log. You can also appreciate the corresponding responses in HBV RNA, E antigen, and correlated antigen in the bottom figure panels. Switching to another siRNA targeting only the S region, RG6346 was given with a single dose to treatment-naive patients and 4 monthly doses at different dosages to leukocyte analog suppressed patient. All patients were eligible for an extended conditional follow-up if the surface antigen levels dropped by more than 1 log from baseline at the end of treatment. This slide shows the response of RG6346 administration to a strong, durable reduction of surface antigen levels in a leukocyte analog suppressed patient receiving 4 monthly dosing. Log reduction in surface antigen is shown in the left diagram, and absolute surface antigen level reduction is shown in the right diagram. By day 112, surface antigen reduction of more than 1 log were observed in all those cohorts compared to none in placebo. Mean surface antigen reductions of 1.4 to 1.8 log from baseline at day 112 were observed in the 3 dosing cohorts. Durability of reduction of greater than 1 log from baseline were maintained out to the day 448, that is 1 year after the last dose, as shown in the cohort with available follow-up time for assessment. This slide shows the individual and mean maximal reduction in surface antigen in both treatment-naive patients and nucleoside-suppressed patients throughout the treatment period and until the data cutoff. The yellow dots represent E negative and purple E positive patients. The dots with plus sign represent patients achieving surface antigen level less than 100 IU per mil, including one treatment-naive patient receiving single dose. We have several other patients receiving multiple doses had more than 2 log reduction of surface antigen. In the leukocyte suppressed patient, 58% of patients achieved surface antigen lower than 100 IU per mil. 92% achieved surface antigen reduction of greater than 1 log, and 75% achieved greater than 1.5 log reduction. And you can see the response was totally independent of the E status. Instead of going through every single parameter in the patients with detectable biomarker levels at the baseline review, it is suffice to say that RG6346 was able to reduce all the quantifiable viral parameters, including HBV DNA, HBV RNA, E antigen, and core-related antigens. The data of this third sRNA via 2218, a single trigger targeting the X region, was just presented in the EASL meeting several weeks ago. In this study, nucleoside analog suppressed patients were given 2 monthly doses of via 2218 at different dosages. Similar to previous sRNA studies, dose proportional response in surface antigen reduction was observed. The maximal responses after these 2 dose regimen was seen at week 20, and the surface antigen reduction had not returned to the baseline up to 48 weeks of follow-up. 71% of patients had more than 1 log reduction of surface antigen, and 12 out of 17 patients achieved a surface antigen level below 100 IU per mil. This slide shows you the better sustained response through 48 weeks in patients receiving the 2 higher doses of via 2218. You can see patients highlighted by the green line with sustained more than 1 log surface antigen reduction were only seen in the lower 2 diagrams, where they received 100 or 200 doses of via 2218. The more profound and sustained effects were also seen for core-related antigen, E antigen, and HBV RNA in patients receiving 200 milligram via 2218 shown by the brown line, than in patients receiving 50 milligram via 2218 shown by the green line. AB-729-001 is an ongoing study examining single-dose administration of 729 in healthy subjects in Part 1, subjects with chronic hepatitis B in Part 2. Repeat dosing of various intervals of 729 are being evaluated in chronic hepatitis B subjects in Part 3. For the interest of time, I will present the results of in nucleoside analog suppressed cohorts, receiving 6 monthly doses of 60 milligram, 3 8-weekly doses of 60 milligram, and 3 8-weekly doses of 90 milligram of 729, a single trigger sRNA targeting the X region. After receiving all these scheduled doses, patients would have option to receive further 8 to 12 weekly doses in the extension phase. The kinetics of surface antigen decline with repeat dosing of 729 are similar across the doses and dosing intervals assessed today. Notably, there appears to be a plateau in surface antigen response around week 20, despite continuous dosing of 729. Nevertheless, 15 out of 20 subjects across the 3 cohorts achieved surface antigen levels less than 100 IU per ml. The figure on the left shows the overlay of the mean surface antigen declines with repeat dosing of 79, 60 milligram, and 90 milligram. Notably, the slopes of the mean surface antigen decline are similar, and a plateau in mean response is reached around the same time, regardless of the dose or dosing interval. As presented in the table on the right, mean declines are similar between doses and dosing interval throughout the treatment period. So far, the effects of combining sRNA with nucleoside analog will study up to 1 year of follow-up. In this particular study, even using the first generation sRNA R520, which only targets the cccDNA-derived surface antigen production, in patients given with 4 to 9 monthly doses after the single dose, we observed continuation of surface antigen decline in E-positive patients during the off-therapy period. In fact, 2 out of 8 patients achieved surface antigen zero clearance 1 to 2 years after the last dose of sRNA. This study illustrated that we may see patients who continue to have off-therapy surface antigen decline and finally lost surface antigen in subsequent follow-up. Moving on to another class of compound knocking down the RNA, the ASO. It was already tested in a phase 1 study. This study recruited both treatment-naive patients and virologically suppressed patients on nucleoside analog. They were randomized patients with 3:1 ratio to GSK836 or placebo. As shown in the figure, after screening, patients enter a 4-week intensive treatment period in which 836 or placebo were administered by subcutaneous injection on day 1, 4, 8, 11, 15, and 22. As such, treatment would be completed within 3 weeks. Significant reduction of surface antigen were observed in both treatment cohorts. In nucleoside therapy cohort, shown on the left graph, 3 out of 4 patients treated with 836 had reduction in surface antigen over 3 logs IU per ml by day 29. 2 patients were below the lower limit of quantification by day 36. For treatment-naive cohort, shown on the right of the graph, 3 patients treated with X36 had surface antigen reduction greater than 3 logs IU per ml, and 2 were below the lower limit of quantification by day 29. All these 6 patients were E-negative patients. 8 out of 10 E-negative patients had more than 1 log reduction of surface antigen. The table on the top shows you the mean surface antigen reduction of 1.6 log for treatment-naive patients and 2.5 log for patients on nucleoside analog compared to no change in placebo arm. As shown in the table on the bottom, among these treatment-naive patients, the HB DNA reduction was 1.7 log, which is significantly higher than practically no change in patients receiving placebo. 3 patients in treatment-naive in a nucleoside analog therapy cohort had ALT flares. The time course of each patient is shown here, with surface antigen in red and ALT in blue. And temporal pattern was observed with the flares with the ALT flares initiating as surface antigen was depleted. A similar profile of ALT flare following surface antigen reduction due to 836 treatment was also seen in the treatment-naive population. And an example is shown here. The time course of ALT and surface antigen is shown in the top figure, and the ALT versus HV-DNA in the bottom figure. All flares are luckily asymptomatic and self-resolving. In addition, these patients showed prolonged surface antigen reduction or surface antigen zero clearance approximately 3 months after the last dose of 836. The left figure shows the peak ALT, and the right figure shows peak ALT under the area under the curve, both plotted against the magnitude of response to treatment for each patient. Blue dots represent treatment-naive patients, and brown dots represent patients on nucleoside therapy. These results show us that the incidence and magnitude of ALT flares is associated with a greater reduction of surface antigen after 836 treatment. Before I end this talk, I would like to show this interesting in vitro and in vivo study presented recently in EASL. This study explored the interactive effects between sRNA 903 and ASO 579. It also explored their effects together with nucleoside analog and CAM. Individually, both the sRNA and ASO showed dose-dependent reductive effects on surface antigen in primary hepatocytes and Hep2 cell lines. Using the isoponomogram analysis, combining both sRNA and ASO showed synergistic effect indicated by the combination indices. Dose reduction of both agents can be done while maintaining the same antiviral effects when used in combination therapy. This slide shows the synergy volume of different combination. It indicates synergism by combining sRNA with ASO and also combining sRNA with tenofovir, while additive effect was seen by combining sRNA with CAM. No added cytotoxicity was observed in all this combination. In vivo mice model experiment, the pink line in the diagram shows additive effect by combining sRNA with ASO. So in summary, combining sRNA and ASO, it has minor synergistic effect in vitro model and additive effect in vivo model. In vitro combination of sRNA, it showed significant synergistic effect with tenofovir and additive effect with CAM. All this synergistic or additive effects upon combination with sRNA or ASO is very welcome to be confirmed in hepatitis B patients. So, ladies and gentlemen, I would like to conclude by saying that functional cure is the current treatment goal for hepatitis B. Viral antigen, in particular surface antigen reduction, by direct antiviral agents may enhance functional cure rate. Gene silencing through RNA inhibition leads to surface antigen reduction is a logical approach. Short-term treatments with sRNA and ASO are able to reduce surface antigen level effectively. Few doses of sRNA are associated with 1.5 to 2 log surface antigen reduction. Intensive ASO treatment seems very promising. Sustained but plateau effects of sRNA are seen. We need to wait. The question remains whether we need to wait and see for more long-term surface antigen reduction or even loss of surface antigen after off-treatment period, or we should add early with other novel antiviral agents, be it a direct antiviral agent plus or minus immunomodulators. With that, I would like to thank for your attention.
Thank you very much, Professor Yuan, for your coverage on the siRNA and the ASO. Before I turn my role to Professor Chitong Chia, please just to remind the audience that if you have any questions while we're waiting for the Q&A at the end, you can chat at the chat box on Q&A to ask any question that you might have. Professor Chitong Chia going to moderate the next for the next speakers. Professor Chia, please.
Okay, thank you. Now it's my good honor to invite Dr. Gish to give talk on the new drug development for HBV, mainly focus on core protein inhibitor. Professor Gish, everyone know him almost, I think. Now he currently work at the Hepatitis B Foundation and he has published numerous important articles in the fields of viral hepatitis B as well as other liver diseases. Now, please, Dr. Gish.
Thank you for having me. There'll be a recorded meeting. Hello, my name is Dr. Robert Gish. Thank you very much for having me as part of this APASL symposium in this specific section on hepatitis B, new drugs in development. I am based in San Diego. I have a practice that spans California and Nevada. I'm the medical director of the Hepatitis B Foundation and work with Loma Linda University, University of Nevada, and UC San Diego. My disclosures are on this slide. We have a very exciting future, and I'll be talking about a segment of this drug development for hepatitis B, specifically these direct-acting antiviral agents that may interfere with viral uptake, viral release, and virus intracellular processing. Let's talk first about nucleic acid polymers. These are oligonucleotides with sequence-independent activity. Here's molecular structures that are detailed here and how this amphipathtic alpha helix aligns with the nucleic acid polymer. There's broad spectrum antiviral activity. This goes into some more detail about interactions with this DNA JB12, forming these spherical subviral particles, including what is used by Delta hepatitis virus. 99.99% of circulating S antigen releases these subviral particles, but we believe these subviral particles may be very involved with immune modulation. Complete virus is about 0.01% circulating surface antigen interactions. These NAPs block assembly and, more importantly, secretion, and then enhance degradation of intracellular S antigen and lysosomes and proteasomes, reducing levels of extracellular surface antigen and intracellular surface antigen. There's interactions with this HPS40 chaperone and DNJ-JB12. This looks at clinical optimization of the nucleic acid polymers, including length activation, these phosphorothioation that takes place. The activity, fortunately, is sequence independent. Rep2139 continues to have improvements with 2O-methylation and 5-methylation that takes place. The Rep401 NAPs dramatically improve responses with TDF and pegylated interferon in terms of S antigen reduction. Concomitant with S reduction, as would be expected, surface antibody rises. This surface antibody rise and S seroconversion would likely relate to enhanced immune control. We have measurements down to 0.05 international units per ml through these studies, and in some studies, more sensitive assay by another log. Now, monotherapy can have up to a 7-log surface antigen reduction at 12 weeks. When used in combination with a nuke and pegylated interferon, can have even deeper suppression of surface antigen, including S seroconversion and potential inactivation of cccDNA. Host-mediated liver enzyme increases are proposed, although further data on immune activation would need to be collected. High rates of functional cure can be in the 40% range. Again, this is surface antigen negative, DNA negative, most importantly in terms of that definition. ALT changes are highlighted here, but no alteration of bilirubin, the most important liver function tests, and these are asymptomatic, and there's been correlations with ALT changes with surface antigen clearance, typically when S antigen is less than 1 international unit per ml. This may signal removal of cccDNA, possibly with integrated HBV DNA. This will need to be documented with intracellular sampling or intrahepatic sampling of liver cells. This may be safe and beneficial, and further data in phase 3 trials are actively awaited. Here's data on 301 and 401, validating this possible NAP mechanism in the clinic by changes in surface antigen content and ratios of surface antibody. Strong surface antigen declines with NAPs can be seen by selective declines of small hepatitis B surface antigen. Data is also highlighted here with p-values of less than 0.01 in 20 and 42 patients, respectively. This S antigen decline with NAPs is often accompanied by clearance of these subviral particles. This may reflect changes in cccDNA and integrated HBV DNA. Again, awaited further information with intrahepatic sampling. Let's now move to what's called the STOPs, which is a similar level of activity. These are oligonucleotide polymers. In the background, as you know, NAPs, we just mentioned in the previous section, reduce circulating surface antigen. STOPs may also be attributed to surface antigen reduction, and we'll highlight this information from Aligos here with their Aligos 1000. This is surface antigen data in the upper left-hand corner, E antigen inhibition, and including viability in the upper right-hand corner. Also core percent relative to MOC and HBV quantitative RNA highlighted in the lower right-hand corner. This is using affinity chromatography, tandem mass spec, and also searches of human proteome databases. And it appears that Aligos, their 10,000 molecule, inhibits multiple HBV molecules, but to different extents. Mechanism of action of the HBV stops is highlighted even further here. The number of basic science data. This Aligos molecule does not co-localize with S antigen or activate nucleic acid sensing immune receptors, TLR and RIG-I data in the top center part of this graph. It does appear to bind to cellular proteins that help function in gene expression, including 5 required for optimal S antigen production. So there may be an inhibition of S production directly. Upper right-hand corner, the stops are binding different host factors with different levels of activity for HBV molecule production. There are major effects on intracellular surface antigen highlighted in the lower right-hand part of the slide. A little bit more information has been postulated here and shown recently at EASL. This mechanism of action has to do with potential knockdowns of RPLP1 and 2 and GRP78, with changes in ubiquination and proteasome degradation of surface antigen. This is an important characterization of STOPs mechanisms. The mechanism of inhibition of S production does appear to be quite complex, and this is not just inhibiting release. This inhibition of intracellular surface antigen precedes S antigen trafficking and secretion. Safety and tolerability of this Aligos molecule 10133, another S antigen stop inhibiting for chronic hepatitis B, are shown here with no SAEs and no TEAEs leading to discontinuation. This is an injectable medication with some local injection site reaction and mild systemic symptoms. There is no clinical changes from a laboratory perspective, EKG or vital signs. So this appears to be appropriate and can be well tolerated after single and 3 weekly doses, and moving into further clinical trials is supported. And of course, at some time, we'd like to have head-to-head comparison of the NAPs from Replicor and the stops from Aligos in comparison of intracellular mechanisms. This is a little bit larger blow-up of this mechanism that we proposed on the previous slide. 5 of these proteins are required for optimal S production. Those are highlighted in the second bullet, including SRSF1, HNRNPA2B1, RPLP2, and GRP78. It's interesting that these 5 proteins have been previously reported to interact with other viruses, viral infections, including HIV, CMV, and flaviviruses. We look forward to more data on the mechanism of action of these important compounds that may be a cornerstone of hepatitis B treatment. A little bit more information on the 10133 molecule in terms of greater potency with a reference to a poly-AC oligonucleotide. Phase 1 study in healthy volunteers. Study design is here, including a SAD and MAD with PK of 3 doses up to 120 and 180 milligrams. Looking at phase 1 healthy human PK data is highlighted here from the SAD and MAD. This is dose up to equal or greater than 125 milligrams, approaching linearity. Healthy volunteer study is highlighted here. No serious adverse events, treatment emergent adverse events, no clinical concerning laboratory data. Dose ranging studies in a phase 1B in chronic hepatitis B subjects. It's important to note that these are E negative patients with a surface antigen level greater than 1,000 IUs. You will be nucleic acid suppressed with DNA undetectable. Different studies, as you know, have looked at different levels of DNA. There'll be up to 6 cohorts with approximately 10 patients per cohort with a placebo control. There'll be PK, safety, and antiviral activity, importantly looking at S antigen reduction. And hopefully they'll be collecting information also on correlated antigen, pregenomic RNA, anti-core antibody titers will also be very important, as well as DNA levels. Let's now switch gears to what we think may be another cornerstone of hepatitis B treatment called CAMs or CBAMs, capsid assembly modulators. This is a very important study from Assembly, the 2158 phase 1, which had 3 different cohorts here, which showed a clearly documented change in HBV DNA, pregenomic RNA. They're highlighted here both graphically and in this table. These CAMs or CPAMs are very interesting in terms of having CAM-A or CAM-N. The A is the aberrant core protein aggregates, and the N is the empty capsids. And you can see both on the right side, the CAM-Ns are listed, including the assembly compounds, and the CAM-aberrant on the left side, including compounds from Roche and all other groups, including a Chinese group for the GLS molecule. This is an oral HBV capsid modulators with graphical demonstration from the early NVR compound, J&J, Roche, and Assembly. These are well tolerated other than some rash and some ALT changes. There's been 3 log reductions in HBV DNA, 2 log reduction in HBV RNA. Binding pocket polymorphisms have had a minimal effect on virologic response. No effect on surface antigen after 28 days of dosing, but longer dosing that went out to 1 to 1.5 years did show some mild or modest S antigen reductions. This is the J&J phase 2 study with interim results out to 24 weeks. This is published in EASL a year ago. We don't have any publicly available data on this. This included placebo plus nucleic acid and the J&J 6379 compound. Part 1 was 75, part 2, 250 milligrams. You can see here the antigen change for HBV DNA on the left. These are E antigen positive, E antigen negative patients with HBV DNA on the right of the left, 2 graphical changes that are seen. On the right side, we have a median change in HBV RNA out to 24 weeks and not treated at steady start in virologically suppressed patients. A little bit more data here on the JADE study with interim results. E antigen positive patients at the start with mean changes in S antigen, seeing some slight changes in E positive, no changes in the E negative. On the right, we're seeing in virologically suppressed patients, no changes in either E positive or E negative. So as expected, we're seeing changes in HBV DNA, HBV RNA. We do need to collect more data on S antigen, E antigen levels to be published as well. This is safety data on that phase 2 JADE study. No clear treatment emergent adverse events except for a few patients with ALT flares. Estimated changes in EGFR that we're seeing in a few patients will need follow-up information as well. Viral response and safety following discontinuation, very important data that was just released. This is Viviprevir from assembly. This is in combination with Nuke, and there was a first double-blind stage out to 24 weeks and an open label up to 76 weeks. Stopping criteria included a composite of HBV DNA quantification and pregenomic RNA and in E antigen negative patients combined or less than 5 international units per ml. Virologic outcomes was basically a universal relapse in these patients with significant changes in ALT as well. There were minimal changes in S antigen from a quantifiable level, and definitely no patients had S antigen loss. It's interesting that 4 E antigen positive patients had E seroconversion after DC, and 45% of patients had restarting Nuke when they met specific lab criteria. The off-treatment information is shown on this slide. On the left, you can see HBe negative patients in the top graphs and E antigen positive patients in the bottom graph. You're looking at DNA levels rising, but may have been a reset. Off treatment, higher viral load HBV DNA patients highlighted in the right orange graphs with larger changes in HBV DNA levels. Predictors of off-treatment viral load appear to be correlated with what type of Nuke that they were taking. This may relate to some type of low-level but durable effect of entecavir or longer viral suppression of entecavir when compared to TAF or TDF. Correlated antigen also appeared to have a relationship to off-treatment HBV DNA levels. Correlated antigen, higher levels, higher chance of having HBV DNA rise and reset. There's also some correlation with age with a 45-year cutoff. Viral response, following discontinuation of abicavir and a Nuke in patients with E positive. Important lessons from this study included no S clearance, no sustained HBV DNA suppression. There appeared to be an additive effect on viral suppression on top of a Nuke with marked reduction in HBV RNA and of course DNA, as we described. ALT flares related to DC of treatment and rebound of HBV DNA. There's no apparent effect specifically of drug-induced liver disease from these CAMs. It's unlikely that CAM plus Nuke would result in a functional cure, and second and third generation CAMs are being developed. Next is a discussion about monoclonal antibodies. This is a phase 1 study of the neutralizing vaccinal monoclonal antibody described as VIR-3434 in chronic hepatitis B patients. So this would be a phase 1b. How could antibodies work? Of course, binding circulating surface antigen would be important. The potential effect on inhibiting viral entry. There could be an effect on cross-presentation and stimulation of T cells, the antibody surface antigen complex. Clearance of surface antigen could take place in an accelerated fashion with delivery to dendritic cells. These immune complexes may be directly immune modulating in and of themselves. You can see the changes or dose changes that took place in the SAD, Part A, Part B, and Part C, highlighted in the right side. These were adults, E antigen negative patients. They were on Nukes for greater than 2 months. They had to be DNA suppressed, less than 100. Surface antigen needed to be less than 3,000. Cirrhotic patients were excluded. AST and ALT needed to be in a modest range, 2 times or less upper limits of normal. HIV, hepatitis C, and Delta infection were excluded as well. Looked to be reasonably safe from an adverse event profile shown on the right side here. Only 1 grade 2 event in cohort 2B that took place as well. No serious adverse events, no study-related discontinuations, no injection site reactions, and importantly here, no clinical or laboratory signs of immune complex disease. The left graph on this slide shows S antigen changes from baseline. Unfortunately, there are minimal changes in ALT. Full analysis of PK is ongoing, complex deposition, immune-related events also. Let's now talk about another method of inhibiting viral entry. That would be with Nucleotide B, which is now called bulevirtide. This medication and this company was recently acquired by Gilead. Most of the research done with Nucleotide has been in Delta infection, but we're going to be looking here at just patients with hepatitis B. There are other drugs that can inhibit uptake. Ezetimibe is one of those, which is an anti-lipid or lipid-lowering medication, and there are cyclosporine analogs that have been proposed. Modest effects on surface antigen levels have been seen, a little bit enhanced with MIR in combination with interferon therapy, but it looks similar to the interferon cohort. It's unlikely that MIR alone would be moved forward for hepatitis B monoinfection. The major development step for MIR has been in delta hepatitis. This combination with Nucleotide with interferon surface antigen response may be enhanced in a subsegment of population that you can see here, where surface antigen clearance took place in 5 patients. It would be important to profile those patients to determine why this subset of patients cleared S antigen and where MIR plus pegylated interferon or bulevirtide plus pegylated interferon may have a role. This is also a patient who cleared S antigen, relapsed briefly during follow-up, but ultimately cleared and included hepatitis B seroconversion to surface antibody positive. A little bit more on bulevirtide and monotherapy in combination with pegylated interferon and chronic delta infection. Of course, this uptake inhibition would be very important because of the requirement for delta and surface antigen for disease transmission and reinfection or uninfected hepatocytes. And this looks at a number of patients with delta infection, co-infection, pegylated interferon monotherapy, 2 milligrams of bulevirtide, 10 milligrams of bulevirtide with pegylated interferon versus 10 milligrams of bulevirtide alone. Let's look at the efficacy shown in the upper right-hand corner. This is results at week 24 with percent of patients with a response, including ALT normalization, delta undetectable, and very importantly, a combined response. It's very interesting to see that we have a 24% response respectively in the 2 and 10 milligrams. There is some suspicion that the higher dose of bulevirtide may increase bile acids, and bile acids in some way may be interacting with a hepatitis B control mechanism. 10 milligrams of bulevirtide alone resulted in a combined response of 50%. Bulevirtide, as you know, has been conditionally approved in the EU for treatment of delta infection, and a global study is ongoing with data to be released in 2023, hopefully, and hopefully approval in multiple other countries where delta is a major infection. Let's now look at one of the more exciting areas that's ongoing. I was here to talk about these direct-acting antiviral agents, but we can't go anywhere without discussing combination therapy. This is the siRNA double trigger combination that Janssen J&J acquired from Arrowhead in combination with the 6379 capsid assembly modulator and nuke therapy. And you can see substantial changes in the right-hand side of this graph with HBV DNA suppression, which is very, very exciting with individual levels that are mapped out. And on the left side, we've got day 113 S antigen change from baseline, including E antigen positive and E antigen negative, showing S antigen reduction. This triple combination was well tolerated. All patients had a greater than 1 log reduction in S antigen, and S antigen reduction, fortunately, in this study, was similar in E positive and E negative patients. I want to thank the organizers for this quick run through of what's happening in the DAA world. There are many other exciting agents here. I'd just like to summarize that I believe that CPAMs will be a cornerstone of therapy for hepatitis B in the near future. Direct-acting antiviral agents such as the NAPs or STOPs may well be switched in or switched out for one of these pillars of what I consider a 4-pillar drug combination for managing hepatitis B. Our next target is S antigen clearance, DNA undetectable in 40% of individuals with treatment of 1 year or less. I also believe strongly the fourth pillar of this will be immune modulation. Of course, one of the pillars, at least in the near term, will be our nucleoside or nucleotide analogs. As you know, we have a later generation, the ATI-2173, that's being developed by Antios, which is a clevidine prodrug, and exciting data that has emerged at APASL as well. And again, I want to thank the organizers for having me as part of this. These APASL online symposiums have been a great gift to the hepatology world during this coronavirus epidemic. And I hope you and your families are safe. And I look forward very much to the panel discussion.
Thank you, Dr. Gish, for your excellent talk. We will have a discussion at the end of the session. So now I would like to invite the last speaker. We always say last but not least, Professor Ning Qin. Professor Ning is professor of medicine at the Tongji Hospital, Tongji Medical College at the Huazhong University for Science and Technology. Professor Ning is also renowned in the field of infectious disease, especially viral hepatitis. Today, her talk would be the new development in the immune modulators for the cure of hepatitis B. Professor Ning, please. Hello, Professor Ning.
Hi, everyone. Thanks for the invitation. This is an honor to join the great session. So today I'm going to share with you about the immune modulators from interferon to toll-like receptor agonist, therapeutic vaccine, engineering T cells, and immune checkpoint inhibitors. So I'm Dr. Chin Lim from Tongji Hospital, the National Medical Center for Major Public Health Event. I'd like to briefly review the history, especially what we learned from the nuke in combination with interferons treatment for the clinical cure or functional cure of CHB patients. For the past over 15 years that our center, in collaboration with many of Chinese colleagues, starting from 2006, that we engaged to have a study that to apply an interferon to viral-suppressed patients. And for the first time, within 48 weeks of PEG interferon, that 8.5% of these patients achieved S antigen loss. And along this line, in 2019, we published a paper in Hepatology International with the name of the study Endeavor, which, again, for the nuke-suppressed CHB patients, we implied a combination of nuke plus interferon 2 plus interleukin 2 plus interferon and therapeutic vaccine. And we've seen for the whole population, a 9.4% of the patients achieved S antigen loss. However, for patients with S antigen less than 1500, that we've seen 25% of them achieved S antigen loss. Further on, we had another clinical trial named ANCHOR study, which was orally presented at AASLD twice for the interim analysis, that we shown for the viral suppressed patients treated with either in combination with PEG interferon or PEG interferon plus GM-CSF with a backbone treatment of nuke. We've seen that over 20% of these patients achieved S antigen loss after 48 weeks of treatment. And also we've seen over 20% of these patients achieved positivity. Therefore, that we think immune response, immune modulation does play a role in these NA-suppressed CHB patients. We did some study for these patients and we found that the toll-like receptor 2 expression and also NKG2C expression were highly expressed in those S antigen declined patients, as well as Treg cells decline in those S antigen declined patients. From this study, we also learned that PEG interferon treatment could enhance the inhibitory effect of NK cells on the differentiation and proliferation of Tregs while interferon gamma expression. And this study thus revealed a novel immune modulating mechanisms of NK cells, which provide a theoretical basis for immune modulators such as interferon alpha as immune therapy agents in treating CHB patients. So it was an honor for us to had an invited letter to Journal of Hepatology in 2015, which we presented or hypothesis that an integration of deep viral suppression with sequential immune modulation to restore antiviral capacity, which could be the future of chronic hepatitis B. But we do understand that with the current available agents, it is quite limited to achieve a higher S antigen loss or a higher functional cure proportion of the patients. Therefore, it is worth to explore further immune modulators for these patients, and it could go to enhance innate immunity, including agonists for toll-like receptor, reg-I, STING, or even APASL family. Induction of HBV-specific immune response, including therapeutic vaccines, or HBV-specific T cells induction. So then we will go into one-to-one. First, the innate immune modulators. Here I listed several of these studies now at phase 1 or phase 2, or they still have some in preclinic. So the toll-like receptor 7 agonist increased response of HBV virus-specific T cells and natural killer cells in patients with CHB, which has already been treated with nukes. In this study that we've seen in the animals that the toll-like receptor 7 could reduce HBV DNA, RNA, and antigens, but do not alter cccDNA. However, this effect does not transfer directly to our patients, as seen in this study that in virally suppressed patients with chronic hepatitis B, that GS9620 was safe and well tolerated. It's showing dose-dependent pharmacodynamic induction of ISGS. However, there is no significant S antigen decline observed in this patient's population. The TOR7 agonist TQA3334 that was appeared to be safe and tolerant with a dose as high as 1.8 milligram. And it has a rapid absorption within half an hour. It can induce slightly a dose-dependent increase of MCP1, the interferon stimulated genes 15 and MX1 and OAS1. The TOR8 agonist from this phase 2 study for both E antigen positive and E antigen negative patients in combination with nukes. It's showing that up to 3 milligram once a week for 24 weeks is safe and well tolerated. However, none of the patients reached to the primary endpoint, which is greater than 1 log of S antigen decline at week 24. It did have patients that with S antigen decline greater than 0.5 log IU per ml in 3 patients in comparison with none of them in placebo. And for week 48, 4 patients had the S antigen decline greater than 0.5 logs, but none in the placebo group. So it showed the effects. For the REG-I agonist, orally REG-I, which in theory should restore the hepatic selective innate and adaptive immune response, especially the type 1 and type 3 interferons signaling pathways, and should induce the antiviral proteins, antiviral effects, shows S antigen response rate at 12 and 24 weeks of treatment superior to interferon plus nukes with a significantly better tolerated profile. So this REG-I agonist phase 2 study that nicely done by one of the speakers, Professor Yuan, that reported in ESO 2019, showing that the dose-dependent response for HBV DNA and HBV RNA, and it also showing S antigen response greater than 0.5 log in 26% of the patients, either 12 or 24 weeks, which is superior to the histological data of interferon plus nuke. And it is superior in A, B, and D genotypes, but similar in genotype C, comparing with that of interferon. I think the good thing is it's well tolerated, even up to 200 milligrams, with no systemic interferon-like effects. So I think we are looking for the phase 2B and C clinical trial data. Another study reported from this year's ESO showing the oral REG-I agonist effects, and it displaying no dose-dependent change in HBV DNA or S antigen with IREG less than 400 milligrams plus nuke, although it was generally safe and well tolerated. So this study was discontinued due to the other related hepatotoxicities. Now we're talking about immune checkpoint inhibitors, including PD-L1, PD-1. So some are in phase 2, some in phase 1. This study showing the anti-PD-1 blockage may contribute to S antigen decline in virally suppressed CHB patients. So this study was showing that, as we can see, compared to the monoclonal antibody to the PD-1, combination of monoclonal antibody plus therapeutic vaccines give a much profound decline of the S antigen, and also the S antigen decline from the baseline, different doses. So here is 0.3 milligram, and so anti-PD-1 blockage may contribute to S antigen decline in very suppressed CHB patients, as we can see in that monoclonal antibody alone or monoclonal antibody plus therapeutic vaccine that showing a beneficial effect in terms of the S antigen change from the baseline. So 12 patients, 10 patients, 12 patients, 10 patients at week 12 and at week 24. So the conclusion is in very suppressed E antigen negative patients, immune checkpoint blockage was well tolerated and led to S antigen decline in most patients and sustained S antigen loss in one patient. So this is studying mainly to explore PD-1 blockage plus IL-15 treatment, whether it could restore specific CD8 T cells reactivity in a short-term nuke-suppressed patients, E antigen negative patients. And this is mainly done in extra vivo, meaning in vitro. So the aim of the study is to see the restoration of the immune response. And it was found that it can restore the reactivity of HBV-specific CD8 positive T cells response with the combination of the two. And the short-term treatment does not reverse T cell exhaustion in 50% of the cases. PD-1 blockage plus mitochondrial reprogramming by IL-15 re-established the antigen-specific T cell reactivity. PD-1 blockage plus IL-15 could be considered as a potential strategy to achieve functional cure, which needs more experiments or more clinical studies, in vivo clinical studies. So how about therapeutic vaccine? Here I listed 4 of these vaccines, some in preclinic, some in phase 2 clinical study. So the BR2179 is aimed to assess the safety and the immunogenicity and earlier antiviral capacity with or without a low dose of interferon in a phase 1b/2a study. And this was reported this year in the conference for ILC. So what they found is for these patients with the 3 or 2 combinations, it exhibits a good safety and tolerability. A limited number of doses of BR2179 containing S, pre-S1 and pre-S2 antigens induced HBV-specific B and T cell response in CHB patients. Further clinical evaluation of these combinations with other treatment agents for functional cure is encouraged. So due to the time limitation, because I only have a few minutes left. So this study has already published showing GS-4774 combined with tenofovir significantly increased virus-specific CD8 positive T cells. And although it did not reduce levels of S antigen in patients, but it strengthens the immune stimulating effects on the CD8 T cells in combination with other antiviral agents. So this is the adenovirus 5-based vaccine, which was shown to be able to induce HBV-specific cellular immune response. And this is phase 1 clinical trial conducted to assess the safety and explore the immunogenicity and the efficacy in CHB patients. As we can see in that, compared to the placebo, 10 to the 9th or 10 to the 10th, 10 to the 11th of this adenovirus-based vaccine, that does induce a slightly change of the S antigen, as well as the immune response. A good profile of the safety and the induced HBV-specific cellular immune response. So this data support further clinical evaluation, especially in combination studies. So this is an interesting study showing FC engineered antibody as a potential therapeutic vaccine for HBV. So the VR3434 is a fully human monoclonal antibody, and the phase 1 study was conducted. And which was in CHB infected patients. As we can see in that, the preliminary results showing most of the patients achieved greater than 1 log of the S antigen decline. And the maximally reduction was generally observed within 7 days. The largest reduction in S antigen were in 80 milligram, the cohort. And the full analysis we are looking for that would be in very near future. So with that, I'd like to finish this presentation by refresh the roadmap that we proposed for functional cure of CHB patients. With all the studies, and particularly the Nuc plus interferons studies that we learn, for those patients, if we could bring their HBV DNA negativity, which is quite possible, which is very firm. Furthermore, if we could bring the S antigen level less than 3,000 IU per ml, then we initiate our immune modulators. Then we see that we could bring 20% of these patients to a functional cure at a treatment duration of 48 or 72 weeks. We also need to have a response guidance therapy for the strategies for the guidance of this treatment for the treatment of these patients. If they can achieve S antigen at week 12 or week 24, less than 200 IU per ml, they have a very high chance to get functional cure at week 48. If they could not achieve S antigen less than 1500, in other words, if the S antigen even greater than 1500 IU per ml at week 12 or week 24, then it's very unlikely for them to achieve S antigen clearance or functional cure at week 48 with the current available treatment agents. So this is what we need to work together to have a higher proportion of treatment success with future functional cure reagents. I also like to take this opportunity to share with you, due to the COVID-19 pandemic, the Critical Care in Hepatology STC Single Topic Conference originally proposed in 2020 September will be postponed to 2022, most likely September. And I would like to welcome all of you to join this conference. So thank you very much for your kind attention, and I'm happy to take any of your questions.
Thank you, Professor Ning. Now it's time for Q&A. So I would like to invite all of the speakers and panelists and Professor Lim and also Professor Sarin, if you are available to for the Q&A. So I'm going to start off by asking some questions that had been asked. We got some question from Professor Maria Butte. She raised her hand. Can we manage so that she can come in? By the way, we got some question regarding loss of surface antigen is clinically meaningful, but how about the reduction of surface antigen titers? So whether is that meaningful, Professor Surim?
I mean, that's an important question. Obviously, my talk was because of time constraint, I wouldn't go into details, but the optimal goal is obviously to achieve HBs loss. But we have indirect evidence that low HBs antigen, let's say less than 100 IU per ml, could be also beneficial in terms of the risk of HCC development that would be decreased. There are cohort studies in, especially in Taiwan, I think, which have shown that. And moreover, the fact that HBs antigen may come not only from cccDNA, but from integrated sequences, where integrants may not be eliminated from the liver may still produce some low-level HBS. So in the end, we might be also satisfied to have, in some patients, a very low HBS levels. That would be, especially if it is sustained after treatment withdrawal.
Jidong, you have any question to ask?
Yes, I have a follow-up question for Professor Zhou Lim. You mentioned that reduction in surface antigen would be meaningful. So my question is, how big reduction is meaningful in clinical phase 2 trials? For example, what is the absolute level should be acceptable for surrogate marker endpoint for phase 2 study?
Yeah, I mean, that's,
Yeah.
yes. That's also another important question that also Professor Yuan and Gish and Ning could also give their opinion on that. But it's true that when we are talking about phase 2 studies where with short-term treatment, where we still don't know what is the best dose, best combination, best schedule, we need to see an effect on HBS antigen. This might not be the HBS loss, the ultimate goal, but I think more than 1 log decline is a minimal goal to achieve, to be meaningful if you want to continue the development of a given strategy. I mean, that would, I think what I would say, I mean, at least 1 log, that would be the minimum if we want to stay simple. I don't know what the others are.
Yes, just follow on the same question, and also to cover on how frequent you monitor surface antigen. That was another question. So Professor Yuan, Professor Ning, and Professor Gish.
Maybe I can share with you about my view on surface antigen reduction. Professor Zhou Lim already mentioned that there has been a study by Taiwan group of review group of patients showing that a patient with undetectable DNA, if the surface antigen is greater than 1,000, then the risk of HCC is significantly higher. So definitely, although we cannot make every patient to have loss of surface antigen, if you look at the review data, we are convinced that the lower the surface antigen, the lower the risk for the complications, number 1. Number 2 is the absolute level that we really want to achieve. If we cannot achieve surface antigen loss, people, I mean, had studied that when patients have a sustained or maintained surface antigen level at a lower level, in particular 100 RU per mil, this group of patients, they have a reasonable chance of getting loss of surface antigen in the future, in the near future. So if you can drive down the surface antigen below 100, some people say 200, some people say 100, then if this, a low level can be maintained after therapy, and then we may expect this patient will have continued surface antigen loss in the near future. So I think, this is another important thing that we may consider. Number 3 is patients who have lower surface antigen. If we really want to stop the nucleoside analogs, the lower the surface antigen, the lower the chance of relapse. So this is another significant when we look at when we assess the loss, the reduction of surface antigen.
Professor Ning, you have any comment on that? And again, how often that you follow surface antigen during the treatment?
Thank you. I fully agree with the previous speaker's opinion. Just to add one more point, is when we observed the patients who treated with nuke plus PEG interferon, we see the lower of the S antigen, the more that the restoration of the immune response, including the innate and adaptive immune response. So this gives a better opportunity for these patients to receive the downstream immune modulator, treatment, and a better chance for them to have the, to have the functional cure. I think we have now regularly monitor the patients' S antigen level for those patients that were treated with interferon. But for NUC-treated patients, it is very difficult for the first few years that to see the S antigen levels decline, especially for those patients whose E antigen level still at a lower level, E antigen still at a positive status. So when those patients who lost their E antigen, then it is the time that you carefully monitor their S antigen level. Yeah, thank you.
Thank you. We got the Professor Gibbs and then Professor Sarin. Oh, okay.
Great. I wanted to make a comment about expectations about S decline. As you saw with the CAMs, we saw very little S change in those because of a different mechanism of action. So with almost no S change, it's still a front runner because of changes in pregenomic RNA and HBV DNA. So really have to look at mechanisms to then help define what S change is actually clinically significant. And in my patients on NUCs, I check quantitative S antigen just once a year. And of course, the ones that maintain super high levels are never going to clear on their NUCs. They'll be good candidates for clinical trials or early use of some of the new combination therapies that should emerge in the next 2 to 3 years. Thank you.
Thank you. Professor Sarin, please.
I enjoyed every bit of this session. So first, thanks to the team, Professor Lim and all of you. I have few comments, and one of them is the paper by the paper on RAP 2139, and the other one I don't remember 2165 or so. I read the paper very carefully and I couldn't find out the difference between the two products. And if any one of you can advise on the product on that and the benefit of using NAP, and then using this in combination with a very good paper on ARC published by our own friend so if you combine the approach of silencing the 5 mRNAs and combine that with RAP, do you think that could be a unique approach? That is question one. Maybe Fabian can help us in that. And the second question is in the same. When you decrease the HbA1c level in this gastro paper, there was a huge rise in the ALT levels. And I was surprised why the ALTs have even gone up to 1400 or so. So the question is not clear by reading the paper. I wanted to ask. That is my second comment. And third, of course, is the approach on new resveratrol and others that they can work on clearing the cccDNA. These were my 3 comments and questions.
Thank you. Professor Gibbs, can you comment on answer one of Professor Sarin's question regarding the NAP?
The question was concerning the different structures in the replicore molecules. It had to do with the, I would call it a preparation. So dosing could be changed, but Shiv, I'll send you that by email and send you the structural differences, okay? Thank you.
And can you also address Bob, then how could you have an ALT flare reaching up to 1400 just by removing HbA1c?
Yes, that's a great question. And this has been raised to Andrew Valiant, the head of the company, multiple times, including is this some type of cellular toxicity from S antigen accumulation? I think it's a major concern, and I think they need to address that, even though it may look okay in clinical trials because there's no changes in bilirubin. this could be extremely problematic and something that becomes commercially developed. So they need to tease out intracellular, intrahepatic events. And I think what I've advised them to do is to do FNA and look at in-cell events that are viral related and also immune related. They still have a ways to go in their drug development. It's a great question.
Okay. Professor Ning, there is a question regarding the role of IL-15.
Oh, okay.
Very
Question, because there are clinical trials that using combination of IL-15 as I presented. In fact, IL-15 had a broad spectrum of immune modulating effects. It was demonstrated in tumor patients that it can activate CD8 positive T cells, CD4, NKT, and NK cells. So it may be one of the master regulators. We also shown in our Endeavor study that, in the OSST study population, that we found that IL-15 released by the NK cells was significantly upregulated for those patients who had a better outcome, such as S antigen decline loss or E antigen seroconversion. Yeah, so IL-15 may be one of the potential, master regulators, for further clinical trial.
Thank you. Professor Yuan, you have you also published a paper regarding NUC stopping. There are questions regarding whether in cirrhotic patients who have lost surface antigen, can NUC be stopped? And one more question regarding in occult hepatitis B infection. That means surface antigen negative, but with advanced liver disease, whether the NUC is indicated.
Thank you very much. Very, important question. For the first one, we don't have study to look at the safety of stopping nucleoside for patients who are already cirrhotic but lost the surface antigen. But in practice, I usually continue nucleoside analog therapy, even they lost the surface antigen, mainly because I don't really know the intrahepatic status inside the liver, because you didn't detect the virus in the blood in terms of DNA and also surface antigen. It doesn't mean that the virus is not active in the liver. It's not so active that you can detect in the blood, but it still may be active in the context of a patient who are already cirrhotic. So number one, I dare not to withdraw the nucleoside analogs. And number two, I think with the nucleoside analog on board, we still need to use them in these cirrhotic patients, because when we look at the most recent data, although it's not yet published, the use of nucleoside analogs seems to decrease the integrated DNA, Hgb DNA, as well as the hepatocyclonal expansion. And when we look at, just look at the action of this nucleoside analogs that can decrease the integration of the Hgb DNA, this is worthwhile to be continued, even the patient who lost the surface antigen. Although I understand this is a very early data, but this has been shown, at least in some preliminary studies. So I don't stop, in general, I don't stop therapy in this group of patients. So for occult hepatitis B, again, is the same argument. If you have a patient who have occult hepatitis B, we will, if they are already on treatment, I don't think I will stop. But if you firstly see this patient, see these patients with occult hepatitis B infection with cirrhosis, I don't really have a good answer. Either way, you can argue for or against. So this is difficult to answer, because these patients, you have no history at all. You don't know the status for our patients.
So I'm going to ask Professor Fabian Surim and Professor Gies whether you are go for the same decision or against Professor Yuan advice?
Well, I think that what's happening now with this integration information that MF just described is that we're going to be treating patients earlier and earlier. I want to just comment that HepDART will be in Cabo San Lucas in December, and there's going to be a very interesting debate between 4 different speakers on should we treat every patient as soon as we identify that they're DNA positive because of this integration issue. I'm moving that direction with my patients. I'm trying to decide reasons not to treat as opposed to looking at all these complex guidelines on reasons to treat.
Yeah, if I can comment on that point, I mean, Bob made a very good point. I mean, we have been discussing for too long who should be treated, and the real question is, do we have reason for not treating? And I think we are building up a lot of evidence step by steps. I mean, the MF studies, recent studies, and following the Bill Mason studies and so on, really showed that the integration process occurs early and with clonal expansion, and patients may actually suffer from these early molecular events, early molecular and cellular events, maybe 10 or 20 years down the road, and these are really strong argument to start as early as possible nucleoside analog therapy, because this is the only thing we have to block replication and block integration as much as possible. So if patients have signs of viral replication, and also more and more proactive in treating them.
But that you mean that in the patient with cirrhotic who have lost surface antigen?
Oh, no. We were, I think with Bob, we were talking about the general population of patients who are HBs positive with some level of viral replication, even without advanced disease. The idea would be to treat as early as possible if there are signs of replication. For cirrhotic patients, it's really, as MF was saying, especially in the occult situation, it's really on a case-per-case basis. It really depends on what you know on the history of the patient.
And just think, if we go out now 7 to 10 years from now, we're going to have multiple therapies, combination, S loss rates will exceed 60 or 70%. The next wave will be to treat everybody who's S antigen positive. I'm not saying that's this decade, but that's not too far away, and it will be within our lifetimes and within the span of our careers.
May I ask?
Yes, please.
May I ask a question for Professor Yuan? In your study of siRNA and ASO, we've seen a nicely faster decline of S antigen. I'm just interested whether you have assessed the immune response of these patients. In
the early studies using this, I mean, siRNA and ASO, they haven't decided to save the lymphocytes for the function. I mean, the immune assessment. But recently, they actually look at some data, in particular the Brutus program, where they actually have some lymphocytes, preserved during this study, and they have been shown very nicely with the drop of the surface antigen, the interferon gamma production and the T cell maturation was, enhanced. So, it is an indirect evidence to show that, with the drop of surface antigen by this siRNA, and in fact also ASO, the GSK also, just recently, same in the same meeting, showing that this drops of surface antigen actually enhance or actually stimulates the T cell maturation and interferon gamma production. So I do believe when we look at the clinical profile of drop of surface antigen and then flare of the ALT in a very good temporal sequence, then this is definitely a proof of immune restoration.
Okay, thank you. Yeah, thanks.
we are running out of time. So before we close the session, I would like to ask all speakers, because we have learned such a lot of things, and we have so many compounds in the clinical trials for early phase clinical trial for the functional cure of chronic hepatitis B. So at the end of the day, in your opinion, what combinations or what kinds of you know, a la carte combination that you predict that's going to be the winner?
I'm going to vote for 4 drug combinations, including immunotherapy, nuke, super nuke, CAMs, and iRNAs. That'll be the first wave. Then we'll start moving in a lot of the other molecular mechanisms. It might be CRISPR, it might be RNA destabilizers, these FXR agonists. But I think that's the first wave. Second wave to be determined.
Professor Ning, you have proposed the guidelines, or that
what I expected, or what I will do if we have multiple compounds, I will bring the HPV DNA down, and then following by S antigen down, and then I will give the immunomodulators. So I hopefully these patients will get S antigen loss and S antibody positivity, but we don't know, you know, whether this antibody would be neutralizing or how long they will sustain, and would that be the same as what we've seen from the, you know, recovery of natural history HPV infection. We don't have data for that yet. Yeah, thank you. That's my opinion.
Hi, thank you. Professor Yuan, do you have any comment on that?
I would go along with the same thinking that, the nucleoside lock is going to be the backbone because it's a standard of therapy. And then I would use, if you ask me, I would add, for the, data that we have at present, I would use the siRNA to, suppress the surface antigen as much as possible before I then consider to use the immunomodulators. And I'm not sure the rapid call, the labs and then the stops. I'm very interested to know more data on this particular compound to see whether the surface antigen reduction, the surface antigen loss, and even with a high rate of seroconversion. So these compounds are very interesting, and I really want to look for that in the near future.
And Professor Lim, you are mastermind for predicting this kind of treatment usually.
Well, but it's a very interesting time. We have so many assets and different mode of action, which is excellent because we can really try and evaluate different combinations based on scientific knowledge. So I think the idea, I just concur with all what has been said. Trying to block viral replication and decrease the pool of cccDNA using nukes and CAMs, come with strategies to decrease S antigen expression with siRNA or antisense, and then see what happens with long-term administration. Whether we will need some immune stimulation is highly likely at this stage. And then we have all these interesting compounds that from which we really need to learn more, because we have to be very careful about safety. Safety should be really also the very important point. We have seen this Riga story, which was really sad, with one patient who died. So that's so we have to be very, very careful. And obviously the future will be on strategy that will target cccDNA directly. So we are hopeful to see that in a decade from now, I guess.
And in your opinion, how long the future is it going to be close, or how many years?
The first generation is now. So I think in a few years they should. We hope that they will be available. It's really a few years, because when you look at all the data that have been presented by Professor Yuan, Gish, and Ning, they are there. It's just a question of phase 3 trials. So we'll see. We are really hopeful. For the other one, it will take more time.
Professor Sarin, please. Do you have any questions?
I was reading with excitement the new long-acting entecavir developed by the Korean colleagues. I'm just trying to look at the name, and I think the name is ECFCP. The ECFCP, the new entecavir, which is staying for almost a week after stopping the drug, and the intracellular levels are extremely high, and also both in HepG2 and the PXB cells. So I just reviewed it, we reviewed it this Monday, and we were wondering whether we would have long-acting nucleoside analogs, and that's a question for everyone. Secondly, I get back to the concept which Bob had answered briefly. If this is the toxicity of the drug, of giving the rep and others, I'm still not sure how the HBsAg got lost. I'm very intrigued with that paper. I wanted to write a letter to editor, but I want someone to explain me that almost 25% HBsAg loss, and maybe MF or someone can answer that. The study by rep. 25% HBsAg loss.
In fact, Professor Sarin, I'm also interested to know the exact mechanism of and then also, in fact, Professor Gish has already, briefly mentioned the cell line studies published, just released in ESO, looking at, in fact, they find that not only blocking the release of a surface antigen, it's actually at different pathway inside the cells. So I think this is a mystery yet that we need to know about the mechanism of action. But I agree. 25% of loss of surface antigen is really amazing. But we really need to have more data, more patients, and also long-term data to confirm this. Very special agent.
Okay.
I have no more questions.
APASL should conduct multi-center, multi-nation study, and Bob can help us in that. And anyway, thank you.
Thank you. I'll turn my role to Professor Jitong Jia to close the webinar.
Well, you have a wonderful moderation. So we are a little bit delayed, but I think everyone still have many questions. So we hope in the next session, next round of the webinar, we can have more discussion. Today, we already have more than 40 minutes discussion. I think this is wonderful. I would like to thank all the speakers, all the audience for your active contribution, for the very good interaction. Also would like to thank the course director, Dr. Lim. I would like to also thank all the APASL steering committee members, EC members, and everyone who makes this webinar works well and make everything go so smoothly. Obviously, the APASL office in Tokyo play a major role. Izumi, also Professor Yokosuka, everyone. I would like to thank you all.
Thank you.
Bye-bye.
Thank you.
Thank you very much. Thank you.
Bye-bye.
Bye.
Mm-hmm.